Good evening. This is Dr. John Bennett, broadcasting from Miami, Florida. Tonight we have another in the series of Hangouts for Parkinsonism education with the leader, a world-renowned leader in Parkinsonism education, Dr. Abdul Rana from Toronto, Canada. And also we're joined by our Japanese contingent, Simon Downs. And we'll say hi to Simon first. Hey, Simon.
Hello. Thank you very much for having me today. I'm looking forward to your presentation, Dr. Rana. I understand that you're an advocate for a comprehensive approach to Parkinsonism. I'm looking forward to your speech on restless leg syndrome.
Okay, welcome, Simon. And Dr. Rana, as Simon said, we'll be talking about restless leg syndrome and Parkinsonism. So welcome, Dr. Rana.
Thank you, Dr. Bennett and Simon.
Okay, let's start things off with what are the symptoms of restless leg syndrome?
Restless leg syndrome is a neurological condition, and most patients describe as a unpleasant and creeping sensation. Some patients would use words of pulling sensation, jumpy feeling in the legs, or numbness in the legs. So they use many diverse words to describe its symptoms. It is an urge to move their legs, and this is more prominent when patients are sitting, and when they start walking, sometimes it's partially or completely relieved. So most patients feel these symptoms in the evenings or in the daytime if they are sitting for a longer period, such as if they are watching a movie in a theater, or if they are sitting doing anything else, or reading, if they're taking a ride in a car, or if they're taking a flight in a plane. So it becomes difficult for them. And sometimes the car or a vehicle has to be stopped, and they have to get out and walk around to relieve this feeling. So these symptoms, since they occur more in the evenings, so they do interfere with sleep of people. So once they go in bed, their legs keep on having these pulling feeling, jumpy feeling, and a restlessness. So they have trouble falling asleep, and sometimes they have to come out of bed and walk around and try to relieve their symptoms and go back to the bed. But soon they go back to bed and they have these symptoms again. So these do interfere with sleep, and their sleep is not fulfilled at nighttime. So some patients, due to this, they feel excessive daytime sleepiness in the day. So the restless leg syndrome not only affects the nighttime quality of life, but it does impact the daytime functioning of the person. Those people who have sedentary jobs, sitting on a desk or working in computers or office-related jobs, they find it difficult, and they have to take frequent breaks and walk around in their office or in the hallway to relieve these symptoms. They also take their attention away from their work, so their work efficiency decreases, and some of these patients, about half of these patients, may have, with sleep, they may have leg jerking or arm jerking, what is commonly referred as periodic leg movements or periodic limb movements of sleep. So these patients would have jerking of their leg or arms every few seconds, which would continue throughout the night. They don't feel it, but their spouse would watch, and therefore their sleep may be broken throughout the night, which is another cause of feeling excessive sleepy during the daytime. Most patients affected are seniors, although it could happen in the younger people, and usually about 50% or so patients may have some relation to their family history of restless leg syndrome. So when we look at cases of restless leg syndrome, we divide them into two types. Either they could be primary RLS without any other medical conditions which are associated with RLS, or they could be, or the RLS could be a secondary condition and it may be associated with other conditions, such as low iron or iron deficiency anemia, or patients with kidney failure who have renal insufficiency, and other patients who have peripheral neuropathy, and it is also associated with some conditions such as Parkinson's disease. And so in common public, the various figures have been reported. About 7 to 10% of patients could be affected with restless leg syndrome, but when you look at a sample of Parkinson's disease population, the prevalence of RLS in these patients have been reported up to 20% or so. So if someone has Parkinson's, so their chances of having restless legs syndrome are higher than the other people. Females who are pregnant, they could have these symptoms throughout the pregnancy, and after the delivery, these symptoms are usually relieved. And sometimes those people who have attention deficit disorder, they may have more prevalence of restless leg syndrome. Some patients, if they are using drugs such as antipsychotics, or they take cold or allergy medications, they can also increase the risk of restless leg syndrome.
Okay, doctor, do you have any questions about that question, Simon? Any comments on what Dr. Rana has talked about?
Yes. Yes, thank you very much. I have a question regarding the medications. What medications can worsen the symptoms of RLS?
Yeah, usually antipsychotics, dopamine blockers, can worsen symptoms of restless leg syndrome. Cold and allergy medication, which some people may use over the counter, they could also worsen the symptoms of restless leg syndrome.
Thank you, doctor. How is restless leg syndrome diagnosed?
For diagnosis of restless leg syndrome, one needs to take a very complete and thorough history. And during history taking, not only symptoms have to be teased out in detail, but they have to be differentiated from other conditions, such as symptoms of polyneuropathy. They could be quite similar to restless leg syndrome, except that these patients don't have any relief of symptoms when they're walking, but otherwise these patients may describe a similar feeling of creeping or burning or tingling as seen in restless leg syndrome. Similarly, patients with Parkinson's disease, they may have a varying of symptoms which could be confused with restless leg syndrome. So history has to be very thorough, very detailed, and then patients also have to be asked about the secondary condition. They have to be asked about if they have any renal insufficiency or iron deficiency anemia, or other conditions which have been associated with restless leg syndrome. Their medications have to be reviewed. Also, the distribution of symptoms have to be asked, whether the symptoms are only in the legs or they are in the upper extremities as well. There have been cases where patients have similar symptoms in the upper extremities in addition to their legs, and in a small minority of cases, some patients report similar symptoms involving their face. So the diagnosis is mainly by history as well as physical examination. Usually physical examination in these patients is normal. You don't find any signs on physical examination, but during history taking, a thorough process of excluding other causes should be done. And if these patients are elderly or they have risk factors for polyneuropathy such as diabetes mellitus or thyroid disease or any history of chemotherapy or any malignancies, then these patients may need other testing, such as nerve connection studies, to rule out any component of polyneuropathy. In some cases, the polyneuropathy may coexist with restless leg syndrome. So the diagnosis is based on history, physical examination, excluding any other causes which could mimic with restless leg syndrome.
Very good. What are the common treatments used in restless leg syndrome?
The patients who have secondary restless leg syndrome, suppose if they have iron deficiency or they have renal failure, or if they have underlying Parkinson's disease, So first job is to address those issues. So those conditions should be treated. They should be investigated, and then they should be treated. So once you treat those conditions, their symptoms of restless leg syndrome improve. If patients are pregnant, then usually after the delivery, the symptoms go away. So you may wait till patients deliver, and the symptoms will go away soon after the delivery. But if you don't see any other secondary causes or any other factors, then patients should be treated with medications. The first-line medications usually are dopamine agonists, such as pramipexole, ropinirole, or rotigotine patch. So these medications usually are given in the beginning, just before the time when the symptoms of restless leg syndrome start, which is usually in the evenings, because the symptoms are maximum in the evening. So we start treatment with the late afternoon or evening dose. And if these symptoms further worsen, or they start happening earlier in the afternoon, then these patients may need a noontime dose. So because the treatment is symptomatic, so it is directed towards the symptoms of patients. Sometimes we use these medications twice a day, like in the early evening and then late in the evening or before bedtime, so that the sleep of patients can be improved. So as I said, the dopamine agonists have been traditionally used as first-line medications in these patients. The dose of dopamine agonists required is much less than required for patients with Parkinson's disease, especially in the milder cases of restless leg syndrome. Other medications which can be used are pregabalin or gabapentin. They could also provide a significant relief of these symptoms to the patients. And sometimes the treatment of Parkinson's disease with levodopa may also offer some relief. And in addition to these, if these patients develop worsening of symptoms and if they become resistant to these medications, then sometimes we may use narcotic medications such as oxycodone.
Wow, that's high test. That's very strong medicine.
Right.
So obviously this is a serious side effect.
Right. Some of the patients could have a very severe restless leg syndrome. I have a 21-year-old patient who just can't sit in the daytime. The moment he sits, his symptoms start. So he has to find a job which involves work, like moving, walking.
Right.
So he works for Best Buy, so he just walks throughout the day. He's showing things to the customers and setting up things in the hallways and shelves, just to avoid his symptoms. So sometimes patients do need very strong medications, and even with the combination of medications, their symptoms may not improve.
Right. Well, what percentage would you say of Parkinsonism patients have restless leg syndrome? Is it a high percentage, a low percentage?
This becomes difficult to tease out because these symptoms are so much similar to other symptoms of Parkinson's disease, such as wearing off symptoms. Patients have the sensory symptoms in the wearing off periods, so it really becomes difficult to differentiate exactly whether they have the restless leg syndrome or they have wearing off symptoms. And also recently we are learning that polyneuropathy is also not uncommon in patients with Parkinson's disease due to a long-term use of levodopa. So those symptoms could also mimic restless leg syndrome. And some patients with diabetes may have some patients with Parkinson's disease may have diabetes as well. A recent relation has been found that patients with Parkinson's disease have increased prevalence of diabetes. So these patients also develop polyneuropathy. So symptoms of polyneuropathy, restless leg syndrome, as well as the sensory symptoms in the wearing off periods of Parkinson's disease are so similar that the exact identification of this diagnosis becomes quite difficult. Even after you do EMG and nerve connection studies, you may not get an answer. So about 20% or so patients with Parkinson's disease is thought to have restless leg syndrome. But patients with restless leg syndrome, interestingly, they have a milder variant of restless leg syndrome as compared to the primary RLS. Like if they don't have Parkinson's disease, somehow it seems that they have more moderate or severe form of Parkinson's disease, of restless leg syndrome, as compared to those who have Parkinson's disease. Their restless leg syndrome is relatively mild.
Very good. Simon, do you have any questions of Dr. Rana?
Yes, please. So I understand that the causes are generally chronic disease, medications, or pregnancy. Would you be, as a physician, looking at, let's say, in a non-clinical setting, you notice somebody that had a restless leg, and you might start to consider perhaps that this might be an indicator of diabetes or some kind of kidney failure? Or to what point would you consider that this might be something serious, or when would it be not serious? How would a layperson?
Yeah, usually it's the other way around. Patients usually have either diabetes first for several years. They develop polyneuropathy, and then you see them. You find some overlap with symptoms of restless leg syndrome. And if patients have a chronic renal insufficiency and they develop renal failure, so they could have symptoms of restless leg syndrome. Usually, if a patient is presenting to us healthy otherwise, without history of diabetes mellitus or kidney disease, so we may investigate maybe serological investigations, but we don't consider that an indicator to go behind. To think that these patients may have renal failure or diabetes. Like in most of the clinical world, it is not considered a indicator of these conditions. Right. But if we see a patient and we suspect, then usually we may do some blood testing, although no investigations are required for this diagnosis.
And in general, are you advocating a natural therapy? Also, any natural therapies are advocated for this?
So far, I'm not aware of any natural treatments which could be used for restless leg syndrome successfully as compared to pharmacological treatments. Some patients have reported that those pneumatic compression stockings might help, or massage might help. But these are all individual reports, anecdotal reports. There's no consensus about these therapies in patients with ALS.
You know, just a general comment, Dr. Rana, after attending all your wonderful talks, is that Parkinsonism is has so many manifestations to it, and so many affects the human body in so many ways, so many facets of manifestations of symptoms.
It is a very complex disease, and it almost affects every system of human body. And it's not only have cognitive effects, it has effect on gastrointestinal system, ocular system, skin conditions are associated with this. And so many other manifestations, psychiatric disease, cognitive dysfunction. So it's a very complex condition. The more you study, more you learn. As a student of neurology and movement disorders, I learn every day a different thing about Parkinson's disease. And from patients, sometimes you may not think about some symptoms, but they would describe you some symptoms which you go back to literature, and they have been reported in some group of patients. So it is quite complex condition.
Yeah, I'm sure Simon will agree. Neurology is one of the most interesting specialties out there, right, Simon?
Yes, fascinating.
Yeah, it's fascinating, the various things. And well, Dr. Rana, anything else to add before we close tonight?
Yeah. Also, it depends on how you look at things. Like if you have a passion for something, or you take interest, you will see more aspects of that condition. Like, sometimes we see a patient who has been seen in ER, and suppose the patient had Parkinson's, and they were seen for something else like acute abdomen or so. So you see a surgeon's note, and all that would be it's so interesting and amusing how they would write. They would just write that the patient is just shaky. That's a little shaky. They would write the patient is just a little shaky. So you can describe the whole Parkinson's as just a little shaky and slow if you want to ignore things, or if they are not, like associated with your domain of study. But if you study it in depth, oh, this is such a complex and such a diverse condition that you will keep on studying always.
Yeah, it's certainly fascinating, and the neurologist has to be such a good physical examiner in Parkinsonism to detect a lot of things that are going on. It's not just a simple cursory 5-minute exam. It's a detailed, deep history and a detailed physical exam.
Right.
Complete in both aspects. Well, Doctor, thank you. Thank you, Simon, for coming tonight from Japan. And thank you, Dr. Rana, for coming again. This will be on Parkinsonism TV. And we'll be seeing you again probably tomorrow night. Thank you, Dr. Rana.
Thank you.
Good night.
Thank you, Dr. Bennett and Simon.
Good night.